Hello, everyone. I hope you're doing well. Welcome to day three of the African Youth AMR Forum 2.0. It's so wonderful to see many of you back as we continue our journey into understanding and combating AMR. As we prepare to listen to our first speaker, maybe we can say on the chat where we are tuning in from, how we are feeling this day. Yeah, as we wait for 2 p.m. Don't be shy. And my name is, I kind of forgot to introduce myself. Hello, everyone. Can you hear me?
Yes, I can get you.
Oh, okay. Sorry about that. My name is Ivy Kairuthi. I'm a final year pharmacy student from Kenya, and I'll be your moderator today. And I'm also very excited to be here. It's been a wonderful 2 days, and I'm very disappointed that it's about to end, but I hope we can continue to fight AMR from our respective countries. I hope these past few days you've been inspired by our speakers, and I hope you'll be inspired today. Let's continue saying where we are from, guys. Ooh, hi,
Hi,
Jules from Rwanda.
can you hear me?
Yes. Yes, Peter, I can hear you.
My name is Peter from Malawi, and I'm excited to
Nice
be
to
part of this session today. I missed it for the past 2 days because I had some network issues, but I'm hoping that today I might get something from this session. Thank you.
Nice to meet you, Peter. We have recorded sessions on YouTube of the past 2 days. You can check them out at your own convenience. I'm loving the diversity. Hi, Yolanda from Zimbabwe. Can also see Joy from Zimbabwe. AMR from Egypt. Okay. Joma from Zimbabwe. It's already 2. So to kick off our day 3 discussions, it's my honor to introduce our first speaker, Dr. Tochi Okwor. Dr. Tochi Okwor is the chair of Nigeria's National AMR Coordination Committee and the coordinator of the National Infection Prevention and Control Program in Nigeria. She has over 18 years of leadership experience in public health and IPC at global, regional, and country levels. She pioneered the institutionalization of infection prevention and control in Nigeria by establishing the national IPC program, Turn Nigeria Orange. Under her leadership, Nigeria's AMRCC was established as a One Health Committee with full quadri-party involvement. She also oversaw the creation of Nigeria's second AMR National Action Plan. Dr. Okwor has participated in various global and regional IPC and AMR agenda-setting endeavors. She co-chaired the IPC Technical Working Group of the African Union Task Force on the novel coronavirus. She is a member of the World Economic Forum's Global Future Council on the future of tackling antimicrobial resistance for the 2023-2024 term. And she's also a member of the WHO STAG AMR. She is a visiting senior lecturer in the College of Medicine Veritas University, Abuja. Dr. Tochi Okwor, thank you for gracing us today. You have the floor.
Thank you. If you can help me project my slides, I'll send them to you, or give me a minute. Are you going to help me?
Yes, we'll share the slides.
Okay, please. Okay, I'd like to start by thanking the organizers of this program for inviting me to just join, welcoming you into your interesting world, to come and share some views with you on antimicrobial resistance, particularly coming from the perspective of taking a holistic approach to the reduction of resistance. And I just have about 25 minutes, I understand. So it's really not, it's a conversation. What I hope to achieve today is to put some things into your minds, get us thinking about certain things. I always am very aware that I am not qualified at all to tell young people of today what to do. My only hope is that I'm able to share from my own perspective what I understand the problem to be. The solution, I am sure you have better solutions than I will ever have. Next slide, please. The next slide. So I am jumping, no, the one before. I'm jumping straight into this because I basically know I'm preaching to the choir right now, and everybody understands that AMR is a problem. And it is because you understand that AMR is a problem that you have organized this very, very important webinar as part of World Antimicrobial Awareness Week. And the drivers of AMR are known. We may continue to understand these drivers and the role they play in more depth, but we do know that humans are responsible for a lot of the antimicrobial resistance going on. We know that it is inevitable that these microorganisms will evolve. It is in their nature to evolve, and part of that evolution is developing resistance. But the things around misuse and overuse of antimicrobials by humans, when we have access or no access to poor access or no access to good quality medicines that are affordable, when somebody is ill and the person is unable to go to hospital or to a health facility and get the right type of antibiotics that is required, these are all the things driving it. The low vaccination rates, diagnostics, poor diagnosis, people being treated without being sure of what ails them, and antibiotics being used in almost like magic. Let's see if this works. To issues around poor water, sanitation, and hygiene. And then the things that go on in the environment when we discharge waste, whether it be waste from human activity, human waste, or waste from production activity, or even waste from agricultural and other manufacturing practices. There are also those drivers that operate at the level of the animal health, both the terrestrial and aquatic animals. Just as there's misuse of antimicrobials in human health, there's also misuse in the animal health when the wrong type of antimicrobials are used, or antimicrobials are used for the wrong purposes in animals. Same issues around vaccination. The same way vaccination can protect human beings from getting infected, the same way vaccination can protect animals from getting infected. So poor levels of vaccination in animal health, lack of awareness in the animal health sector, knowledge about antimicrobial resistance and the things that drive it in the animal health sector. And when animals move from one location to the other, they also move antimicrobial resistance with it. There are also issues, drivers that operate at the level of food and feed production. When our food from farm to plate, when we don't pay attention to the quality of the food from the farm down to our plate, that whole food chain that whole value chain in the food production, they can also drive antimicrobial resistance. There are also those ones that operate at the plant and the crop level. So we can see that the things that drive antimicrobial resistance are multifaceted, they operate across sectors. And that's why we say that in order for us to respond right, we must respond across sectors in what we call One Health, knowing that the impact can be huge. It will impact our food and feed production. It will impact us in the form of that illnesses will increase, length of illnesses will increase, and also mortality, death from infectious diseases will increase in both humans and animals. We also look at it from the economic part of it. There's loss of productivity. When human beings are ill people don't work. When animals are sick animals can't yield. They can't be productive, right? And all these things will lead to increasing cost of healthcare expenditure. It will also lead to increasing cost of food. And we can then imagine the impact to us all. And that's why I see a lot of projections that don't look good if things remain the way it is over by 2030, by 2050. And I always like to talk to young people because this is a problem, just like climate change, that is happening now into the future, but will impact more the young people of today. Next slide. And talking about the impact, while everybody is impacted in every geography, in every location, evidence is very, very clear that the way those of us from the low and middle income countries will feel this is not the same in terms of the impact, the weight of this impact. Those of us from the low and middle income countries will feel this more. So if you look at this graph, what you see here is the impact, the AMR associated deaths, that is deaths that are associated with antimicrobial resistance per 100,000 population. And when you look at the countries that are in the low and middle income countries, and the one that really, really becomes very clear once you look at this is the sub-Saharan Africa, where you see that up to nearly 100 per 100,000 population annually will be impacted by antimicrobial resistance. Next slide. If you then go further to look at, yes, everybody's impacted, but it's painful to realize that everyone is at risk, including those that haven't even taken antibiotics before. You see newborn babies that are born colonized by resistant organisms. You see newborn babies that are born maybe because they're premature and then they're being taken care of in hospitals, and then they get infected with resistant microorganisms in hospitals. These children haven't taken antibiotics. They haven't contributed to, these babies haven't taken antibiotics. They haven't contributed to the problem. Yet they're already from birth having to deal with the impacts of antimicrobial resistance. You also have the very old among us who, because of the virtue of age, become a bit more vulnerable to infections because their immune system slightly not as great as it should be. Those that are in resource-constrained settings, so even in the same geographical location, there are those ones that for some reasons that have to do with the social determinants of health, because of income disparities, because of the things that operate in society at the level of society, they also become more vulnerable to infections because they do not have the adequate resources to provide what is required to prevent infections, for instance. Next slide, please. So I'll jump straight and bring us to some evidence we already have, because it is not my intention to teach or to go into any detail of the science of this and the science of that. I want us to get practical. I want to present to us what the latest Lancet series has shown about what could be best buys as we consider really how we can tackle antimicrobial resistance, particularly in low and middle income settings. They identify 3 things that I find that really can be very valuable if we dig deep in and see what we can do with this data. So first of all, the Lancet showed that if we align infection prevention and control standards in low and middle income settings, right, with those with high income settings. So if we move healthcare, infection prevention and control in low and middle income countries closer to what it is in high and middle income countries, we could prevent up to 337,000 deaths annually. So what we are saying is closing the gap between high and middle income countries, high and low and middle income countries, that if we make an attempt to move infection prevention and control standards to get closer to what operates in high income countries, we can reduce healthcare associated, we can reduce mortality from antimicrobial resistance by up to 337,000 deaths. Let us look at the scenario of access to water, sanitation, and hygiene infrastructure. What the Lancet series shows is that if we're able to achieve universal access to water, sanitation, and hygiene, if we're able to get services to people that need it in society, irrespective of income status, socioeconomic status, if we get universal access, we get people to have universal access to water, hygiene, and sanitation, we can prevent up to 247,800 deaths per annum, just by making sure that when somebody needs to have access to water to wash, and the person is able to turn on a tap, drink water that is clean, have access to hygiene services, we can reduce healthcare-associated infections by, I keep saying healthcare-associated infection because of my IPC, but we can reduce antimicrobial resistant deaths that are associated with antimicrobial resistance by 247,800. Now, look at the vaccination side of things. The same Lancet also shows that if we're able to achieve universal coverage of high priority pediatric vaccinations, such as those that will vaccinate against pneumococcus, rotavirus, and respiratory syncytial virus, it could prevent up to 181,500 deaths. I will pause and let this sink in. You can see that what is being proposed here are not new things. What this is basically saying is that if we can attempt to close the gap in IPC standards, align what operates in high income countries to low and middle income countries, can bring the low and middle income countries closer to what operates in the high and middle and high income countries, we can reduce AMR associated deaths by 337,000 deaths. And if you can give more people access to good quality water, sanitation, hygiene infrastructure, which is really a human right, everybody should have access to that, then we can reduce deaths that are associated with antimicrobial resistance by up to 247,800 per annum. And if we can just get every child that needs an immunization to receive childhood immunization, which is still what every child that is born into this world should expect, that we have put mechanisms in place to receive them and give them a fighting chance in life through vaccination, that we can reduce antimicrobial resistance, deaths that are associated with antimicrobial resistance by up to 181,500 deaths. And now let's think back to, I'm sure yesterday we have had conversations around the high-level political declaration that has mandated everybody to reduce. We're all committed now. All the countries are committed to reducing deaths that are associated with antimicrobial resistance by 10% of what it was in 2019, by that baseline, 10%. So we can already begin to see that we don't even need to look far to see how we can achieve the 10% if we can target some of these things I've mentioned here. I'm intentionally being practical. I'm intentionally not introducing any complex science. I'm just bringing this to see there are things that can be done, they are measurable, they have impact, and it's really not rocket science. Next slide, please. But I have shared with you what the Lancet series shows, that there can be interventions that will have significant impact in health in low and middle income countries. But this is a picture that I took from from it's the World Bank document. The World Bank document on AMR is the joint monitoring program of it's the joint monitoring program of WHO and UNICEF and Water Aid, where they showed the picture of water, sanitation, and hygiene and IPC, infection prevention and control in healthcare settings. Bear in mind that we said that if we can get IPC to be closer to what it is in high middle income countries, if you can get universal access to vaccinations, if you can get universal access to water, sanitation, and hygiene, we really can make tangible changes. But see the picture that we have. The picture we have is that up to 90% of health workers, and this is a global picture, of health workers do not adhere to recommended hand hygiene practices. And hand hygiene is one of those key things that needs to happen for healthcare to be safe. One of the key ways we can prevent healthcare-associated infection, that is through infection prevention and control, is hand hygiene. But the picture is showing us that up to 90% of health workers do not adhere to recommended hand hygiene practices. And the reasons why they do not are many, but among them is that there's a lack of enabling environment. Even for those that want to do the hand hygiene, they are not able to because of lack of infrastructure. The environment is not enabling. Maybe they're overworked. Even being underpaid, not having access to the running water, not having access to alcohol-based hand, there are many reasons that make it difficult for up to 90% of health workers to adhere to recommended hand hygiene. Another important fact that I would like us to see is that 1 in 3 healthcare facilities globally do not have hand hygiene materials at the point of care. When we are teaching or guiding or supporting health workers to understand what needs to be done to prevent infections in healthcare, it is that at what we call the point of care, there are 5 moments where we tell every health worker that if you're able to do hand hygiene at these 5 moments, you will get your hands safe. If you're able to do hand hygiene at those 5 moments, using the right technique and doing it for the right duration, that you can prevent infection using hand hygiene. But what the data is showing is that 1 in 3 health facilities globally do not have the hand hygiene materials at the point of care. So we know those moments where infection prevention and control can be achieved through hand hygiene, but the data is showing us that 1 in 3 healthcare facilities globally cannot achieve this. Another factor that I would like us to pay attention to is then that 1 in 10 health facilities globally have no sanitation services. This is shocking and should shock anybody, but that is the reality. And we know, we've mentioned it, that water, sanitation, and hand hygiene and hygiene infrastructure, that if we're able to get it universally accessible, both in communities and in health facilities, we can reduce we can reduce antimicrobial resistance, deaths that are associated with antimicrobial resistance, that we can reduce them. But here we see that 1 in 10 health facilities have no access to sanitation services. And the final one here is that more than 700 million people are using healthcare facilities with no water service. I'll pause here and let this sink in. We have said that water, sanitation, and hygiene is relevant. It's very, very important. If we are going to keep clean, if we are going to keep equipment that we use in hospitals clean, if we are going to maintain personal hygiene in communities and at home, we need water. You can't have a health facility without water. But here, what the data is showing us is that more than 700 million people are using healthcare facilities with no water service. I know what this means. It means that infection will continue to thrive. And the more you have infection, the more you have the need to use antibiotics, and the more you're putting selection pressure, the more you're putting pressure on antimicrobial resistance to develop. Next slide. Now, I want to bring it close. I want to bring the connection between water, sanitation, and hygiene and the Sustainable Development Goals. They are related. And the thing really about most of the things we need to do to make an impact in global health, to make an impact in public health, or to make an impact in anything we want to prevent, they are basically all the same at the end of the day. Whether you're addressing them as sustainable development goals or you're addressing them from individual programmatic perspective, they're really the same. So if you look at the SDGs and the WASH targets in Africa, this is, I got it from the Progress on Drinking Water, Sanitation and Hygiene in Africa, the 2000 to 2020 report. This was like 5 years into the SDG. The UNICEF and WHO looked into, so how are we, what are the achievements, and what needs to be done. And I want you to pay attention, please, to the acceleration that needs to happen. There's a lot of lagging behind, but to see the rate of acceleration that needs to happen if we will meet what the target is for 2030. Let's start with the one in blue, the light blue, pale blue, and the dark blue. The light blue one on the right is that basic drinking water and safely managed drinking water. So when you look at the basic drinking water, which is the lighter colored blue on the left, my left, which will be your right, you see that from what the target is for 2030, which is that 100 up there, as at 20, this was done in 2020, right? As at 2020, for safely managed drinking water, whatever it is we are doing towards that, we need to accelerate it 12 times. Whatever effort we are putting, we need to accelerate it 12 times to get to what that target is by 2030. For basic drinking water, we have to accelerate it 4 times, whatever the efforts were. Now let us look at the one in the middle, which is looking at no open defecation, eliminating open defecation, the improving basic sanitation and safely managed sanitation. For open defecation, from what it was, and this is the target for Africa, and different parts of Africa are doing badly. Some are doing better than others, but this is the overall picture for Africa. If we need to get close to what the target is for 2030, we need to accelerate whatever we are doing, double. We need to double efforts. And this doubling effort is just what we need to do to make sure that people do not defecate in the open place, that the defecation is managed and is not in the open where it can contaminate everything. Then when we look at the basic sanitation, we need to accelerate our efforts 14 times. And then for safely managed sanitation, we need to accelerate our efforts 20 times. When you look at basic hygiene, whatever we're doing to ensure that human beings are able to achieve basic hygiene, have the right type of water, have the right type of materials to achieve basic hygiene, we need to accelerate effort 42 times. Why I have brought this out is it's easy to put these things into, oh, AMR is this, AMR is that, but I'm trying to put in our minds that for the prevention side of it, there are practical things, there are things that must be done, and there are gaps that already exist, and all of us must come together to fill this gap if we'll make any meaningful difference. And this future we are talking about is the future of the young people. The pharmacy student here now is going to be an established pharmacist by 2030, where you then be dealing with all these issues if they're not addressed now. The young medical student is then going to be dealing with infections because of actions that we're not taking now. The young engineer may be limited in what he can do because he's been incapacitated by an infection that makes it difficult for him. It could impact those that want to go to space because it could be that infections will incapacitate. So the consequences are there for young people. So this acceleration that needs to be done, it is for young people to pay attention to these accelerations and mandate that we all take action. Next slide. Well, to continue to show the numbers, 411 million people in Africa lack basic drinking water services. And when you look at the countries with the highest numbers, they're all there. But it is shocking that 411 million people lack basic drinking water services. And this is as at 2020. Next slide. The next slide. millions of people are defecating in the open. 208 million people in Africa practice open defecation. Next slide. And why am I taking time to bring these things? It is because, you remember, we started from that the Lancet series that has shown us that if we can make a difference in these three broad things, we can really impact tangible numbers. We then go to immunization, which is a key preventive effort, because how immunization works, vaccination, if you vaccinate somebody and that vaccination is effective, it means that the person will not develop that infection, or even if he develops it, it won't be a severe one. And many of the things that make us to take antibiotics are viral, and a lot of the viral infections can be vaccinated against. And then for childhood immunization, and we mentioned it for something like the pneumococcus and the rotavirus, if we can get those priority vaccinations done, over 181,000 deaths can be avoided. But let's look at what the picture is in Africa. You find out that we have low or declining vaccination coverage in Africa. And vaccination is something we have known for very, 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 very long time, that vaccination is very, very cost effective in preventing anything. But you look at the table here, what it shows is from 2019 to 2022, what has been the situation? The summary of it all is that compared to 2019 numbers, the percentage of children with 0-dose vaccination has been on the increase, at least as at 2020, meaning children that didn't even receive 1 dose of a vaccine, DPT, or called diphtheria, pertussis, and tetanus vaccine, compared to 16% of surviving children. So keyword surviving children, meaning that a lot of children still die from childhood infections, things around the early years of life. But of those that survive, compared to 16% of the children in 2019 that didn't even receive 1 dose of DPT, it rose in 2020 to 20.2%. And childhood vaccinations are things we know that work. They've been there like forever. I know this, the thing now, that what this means is a lot of these children now they're no longer within that bracket that one will routinely take them to hospital, right, to receive vaccination. So it is what to do. This is critical because vaccination is there, is established. The mechanisms for delivering this are there. Why is it not happening? Is it vaccine hesitancy? Is it because of poor infrastructure? Is it because of health system issues? What are those things? Is it because of socioeconomic situations that mothers can't take decisions to take their children for vaccination? Is it because families can't even afford the transport to go to take their children for vaccination? Is it because health workers are not even the community level workers who should be close enough to communities to deliver these immunizations are not there? We must unbundle this and understand what is happening and intervene to save those lives that are associated with AMR that we have shown earlier. Then let us look at the Haemophilus influenza B, pneumococcal vaccine, and rotavirus vaccinations, the coverage. What you see happening here is I see that around 2020, it started coming down, but since then, it has remained a plateau. And if you look back at the slide I presented early, numbers we actually counted. The Lancet series provided us with a number that if we are able to achieve universal coverage of high priority pediatric vaccines, such as those against rotavirus, those against pneumococci, and those against respiratory syncytial virus, we could prevent up to 181,500 AMR-associated deaths. But here we are looking at the picture. It was coming down, now it's plateaued. Doesn't make sense. We must do something because these are known things. It not only will prevent antimicrobial resistance, it will give these children who are the future a fighting chance, because apart from antimicrobial resistance, these are also dangerous infections that we are trying to prevent for them. Next slide, please. I see some raised their hand. Let's shortly take note of your questions and then we can address it. So as I wind down, the thing is, what should we do? Take us back to, maybe there's a lesson to learn from 1854. We can learn a thing or two. No, to the next slide. The next slide. So I intentionally am taking us back to 1854 because there's something to be learned. The picture here is a picture of John Snow. He was actually an obstetrician in London at that time, where there was this massive explosive outbreak of cholera around Broad Street in London then. And I'll read a quote. I got this quote from this the journal I got it from, and then the source is the Creative Commons photograph by Justin. So the quote is, the Broad Street Pump, John Snow Memorial. So this pump here is the Broad Street Pump, is a John Snow Memorial in London. In 1854, an epidemic of cholera affected residents of Soho district. Dr. John Snow surveyed deaths reported in the homes, mostly near the pump, and used it for their drinking water. His documented evidence suggested that contaminated water from this pump was the source of the epidemic. Just remove the handle so that people can pump water, and the already declining epidemic due to people living in the area ceased entirely. This is simplistic, but I want you to really, really read this. That prevention is massive in public health. He found out basically that those that are supplied by the Upper Thames versus the Lower Thames, the different water companies supplying different parts of London, that the people supplied by a certain water company versus the one supplied by Sodok versus the one supplied by Vauxhall, that something was going on. But while they were trying to understand that, he just went, what they did at that time was remove the handle of this pump so that people could no longer pump water from this handle to understand what's going on. Why have I shown you this? I have shown us that there are some things we can even do now while we're waiting for the complex things to happen. Vaccination here is with us. Let's crank up vaccination. People are defecating outside. Can we get a better way to have people relieve themselves? We talk about water, sanitation, and hygiene while we are waiting for the amazing stuff and all the hi-fi things that need to happen. Can we at least make sure that people have access to basic water, sanitation, and hygiene infrastructure? Can we at least try to reduce that 700 million people do not have water? If some people can have water, no reason why others can have clean water. That is what I want us to see here. That is a lesson to be learned here. There may just be a very simple thing that we can do for now while we are waiting for the bigger, more complicated and complex stuff. So that's why I've taken us back to 1854 to learn a thing or two, that something as simple as removing the handle of a pump can actually help to stop something. So could it be that something as simple as installing handles of water in places can also be the way back for us? Next slide. And still on the question of what can we do? You see, we say antimicrobial resistance is a big issue, is a global health threat, and what have you. But anytime I speak to young people, I think about my own when I was young. When you're young, you're invincible. You feel like a god, and you're truly gods in your own right. Right now we have bases in space that are manned by human beings. What should that tell us? There's nothing impossible for us to do as humans, as humanity. Nothing we put our minds to. We only need to, first of all, appreciate the scale of the problem. We only need to really, really agree that this is a problem that we must all apply ourselves to. And it is for this reason that I never prescribe to young people. We can only have a conversation like this, and I tell you my own side from where I understand the problem. But the solution, you hold the solutions more than I ever can hold it. Next slide. And that is why I can only say a few things. God forbid that I prescribe to you what to say. But we must get serious with water, sanitation, and hygiene in community and in healthcare facilities. It is no longer something that we can play politics with. It's no longer something that governments and society can afford not to put enough money to. It's not something we can no longer afford to not come together and put an end to any human being in this planet not having access to water, sanitation, and hygiene, even if it's the most basic of it all. This is the equivalent of removing the handle of the Broadway tap. We must aim in hospitals for what we call the minimum requirements for infection prevention and control in all healthcare facilities. Honestly, I do not know any part of the world where there are infinite number of healthcare facilities. There's no part of the world, there's no country in any part of the world where you cannot count the hospitals, the health facilities in that country, even if the health facilities are hundreds of thousands. And therefore, if we can count them, no reason why we cannot aim to have them meet at least the minimum requirements where they become safer for healthcare. We also have to bring together antimicrobial stewardship and infection prevention and control. When people will inevitably need to have access to antimicrobials, we must make sure that it's bundled with infection prevention and control. We must make sure it's the right dose, the right type of antibiotics, the right diagnosis, the right dose, given at the right time, under the right conditions. These things we must aim to make sure we achieve that. We have also mentioned that the drivers are multifaceted. We can no longer look at any of these things from one lens. We must always realize that human, animal, environment, we are all interconnected. And for the youth, you really have the solution. You really have the solution. The only thing is that you must take the box, break it open, remove the boundaries to your thinking. Remove the boundaries, free your mind, and reappraise the situation and take on the challenge. Antimicrobial resistance, whether we are thinking of infection prevention and control or stewardship, it is not a health problem. It's not something for only the medical people. It's not only something for the pharmacy. It's not only something for the lab people. No, get your engineering friends involved. There's a solution that they hold. It is engineers that will engineer physics out of your water. Get your town planning colleagues, those ones in urban and regional planning, those ones that are how our cities are planned, how our transportation system goes. All these things will impact antimicrobial resistance. Get your colleagues in the arts interested. The people in the arts, they have a way of communicating. They have a way of understanding problems. They could sing this in a song. They can draw the attention of the politicians who mentioned the water, sanitation, and hygiene. It could be like our friends and our colleagues in the arts and craft that will be able to tell this story in a compelling enough way to get the people that need to act. Get civil society interested. Get your colleagues in the legal professions interested. There are some things that we can only tackle through legal frameworks. But I have no answer. And this is the limit what I can put down on this slide. But I'm hoping that I would have communicated to you that as young people, you have the answer. Let nobody dictate to you what you can do. The only thing we can do as this World Antimicrobial Awareness Week says is to educate, but more importantly, advocate. But the action is your own. You know your strengths. You know that innate resources that come by just being a young person of this generation. Deploy it to this problem and you'll be shocked about what you can achieve. Next slide. And it's on that note that I'll say thank you for inviting me and I'll welcome any questions.
Thank you, Dr. Okwor, for your very insightful presentation. One major takeaway that I'm sure you've all had is the importance of sanitation in preventing infections. Due to the interest of time, we'll take only one question. And Prince has been raising his hand for quite a long time, so we'll take his question. Prince, you
Okay,
have...
Prince, I'm waiting.
Prince, you can unmute and speak.
Hello, am I loud?
Yes, Prince.
Yes.
Am I loud?
Yes, we can get you.
Okay, Prince P. David from Liberia. My question, firstly, let me commend the presenter. Our presentation was very amazing. I do commend her for the splendid delivery. But all what she said, it is somehow interrelated to the other disciplines. But can we, in the meantime, can we find urgent thing that we can do to carry on some reduction in the number of people that are now currently accessing the quality water sanitation? I'm experiencing serious network problem. What's the basic thing that we can do now to reduce the number of people that they are not accessing quality water? It is require political will.
Okay, it was breaking, but not very clear. But I think if what I heard is what specific thing can we do now to increase the number of people that have access to sanitation, access to good quality water? That's what I think I heard Prince say. And thank you, Prince, for that question. Is exactly because of this sort of question that I presented it the way I did. It will vary from location to location. But the whole idea is to understand what will be the best approach. In some settings, it could make it a political issue. You could get your politicians through your civil society organization to say, if you're going to be a councillor, if you're going to be a local government chairman, if you're going to get voted in any political position, you must put providing water on the agenda. It must be on your manifesto, and we hold you accountable. It could also be that people may start paying attention and getting interested in finding innovative engineering, innovative ways to make this access slightly cheaper or easier to deploy in hard-to-reach areas. But like I mentioned, I will not sit here and suggest or prescribe to you what to do. My intention is to put it out like this and hoping that the organizers of this program will take on a challenge later to say, okay, can young people say how they can help to reach these targets that are here? Thank you.
I can see many hands. So please, George, can you just quickly ask a question? And the next speaker is already ready. Just quickly ask so that Dr. Toshi can reply. George.
Okay, thank you so much for this chance. Mine is not a question, but I just want to commend what Dr. Okoras just said on hygiene. I think hygiene is very important. In addition to what she has just presented on the AMR, hygiene could also play a major role in reducing the soil transmitted candidiasis diseases and schistosomiasis, which is very important. And these ones are common problems affecting children in Africa. Therefore, just to add on what Dr. Okwara has just presented, just that if we were to consider that hygiene, we could save much of many children and many other people. Thank you so much, Doctor, for that presentation on hygiene. Thank you. Over.
Right. Thank you. Milimo, please, you have a question. I can see your hand is up. You'll be the last question for today, for this session. Milimo, please, you can just quickly speak.
Thank you, moderator. Thank you so much. It is worrisome. Let me just state it is worrisome to acknowledge the fact that over 90% of primary healthcare providers do not adequately adhere to or do not have access to proper wash mechanisms. As a result, issues to do with IPC are not effectively implemented. My question is, what can we do as primary healthcare workers if we are to change the narrative and, contribute to adequate infection prevention control mechanisms to lessen the rates of infections that leads to demand for consumption of antimicrobials? Thank you.
Okay, thank you. I'm mindful that the next presenter is waiting, so you know that I refer to what called the minimum, and it's really not even primary healthcare providers. It is up to 90% of health workers do not adhere to recommended hand hygiene, and the reasons are mainly from lack of infrastructure to lack of availability, to behavioral change, to behavior of health workers. Even when you provide it, some health workers do not use it. So what I think is the best way to do is to, first of all, understand that this is a problem, and then plan in an organized way to have what we call an infection prevention and control program, whether it's in your health facility, but if it's a primary healthcare, have one that is organized at some sort of local level to provide the training, first of all, for health workers to understand even when and how they need to do hand hygiene, and then advocate to the providers of healthcare, the government, whether it's public or private, whoever is in charge of getting these things in the health facilities, to find ways of advocating. We have to learn communication skills, be to achieve what we call the minimum requirement for where having a legal framework that mandates certain things can also be useful. I'll stop there, knowing that the next presenter is waiting.
Thank you so much, Dr. Awkward. Thomas, kindly write your question on the chat. Dr. Awkward will address it. It is my honor to introduce our next speaker, Dr. Ayodele Majekodunmi. Ayodele Majekodunmi is a One Health epidemiologist with over 15 years experience in academia and international development. She works with the FAO Nigeria as the National Project Coordinator for the Emergency Center for Transboundary Animal Diseases. Ayodele holds a PhD in veterinary epidemiology from the University of Edinburgh, an MSc in medical parasitology from the London School of Hygiene and Tropical Medicine, and a BSc in veterinary science from the Royal Veterinary College. She has worked as Zhejiang University, University of Edinburgh, and University of Ghana, running research projects on mainstreaming integrated prevention and control of infectious diseases and antimicrobial resistance through health system strengthening using a One Health approach. She is an honorary research fellow at the University of Edinburgh. Thank you, Dr. Ayodele, for gracing us today. You have the floor.
Thank you so much, Ivy, and thank you to IPSF for inviting me to join you for this AMR Youth Forum. It's a pleasure to be here. So if you permit, may I share my screen?
Doctor, are you currently unable to share it?
No, I'm able to share.
Yeah, you can share.
Please confirm you can see my screen.
Yes, we can see.
Okay. So thank you once again for having me to give this presentation on priority research areas in AMR, shaping the future of global health responses. It's a pleasure to be talking about this very important subject during World AMR Awareness Week. So we've said we are talking about research in AMR, but why research in AMR? Why do we need to be talking about this? If we break it into two, and we say, first of all, why AMR? Everybody who is on this call probably understands that, but we can revisit that very quickly. AMR is a global health priority that causes almost 5 million deaths a year, and over $100 trillion annually in losses to the global economy. It also causes negative impacts on healthcare systems and socioeconomic development through treatment failure, longer hospital stays, the fact that we need to use ever more expensive and advanced antibiotics and treatment procedures. And of course, we have the risk of resistant hospital-acquired infections. And all of this negative impact tends to be higher in lower and middle income countries. Of course, this impact is not limited to humans alone, but is seen across all of the One Health sectors. So we have similar problems within animals, and we have the issue of antimicrobial resistant pathogens in the environment, antimicrobial residues, antimicrobial resistant genes. So the One Health approach is an integral part of AMR because the negative impacts of AMR are felt across the One Health sectors, human, animal, and environmental health. They limit our capacity to have healthy animals, healthy humans, and healthy ecosystems. And they have whole of society approaches because AMR is present at local, national, regional, and global levels. And AMR affects and is affected by issues of inclusivity, equity, and access. And it varies depending on whether we are in a rural, urban, depending on the setting, whether this is rural or urban or otherwise. And so the collaboration, communication, coordination, and capacity building that is inherent in the One Health approach is also necessary in the way that we tackle AMR. And to have a truly One Health approach, we need to ensure that these 5 principles are considered. We have equity, we have inclusion, we have equilibrium between different systems, different actors, different sectors. We have stewardship of the resources that we have, including antimicrobials. And of course, we need to be working and acting in a multi-sectoral and transdisciplinary way. So the One Health impact of AMR requires a One Health approach to prevention and mitigation. So we've seen very clearly why AMR is a key priority. So why research? Out of all the things that we could be doing within AMR, we've just heard a fantastic talk about IPC from Dr. Tochi Okwor. It's a pleasure to be following her presentation with mine. But we have IPC, we have surveillance, we have monitoring, we have evaluation, we have stewardship, we have all of these different things. Why do we say that research is also a priority? If we look at evidence from many of the high-level global documents and meetings on AMR, where you have all of the different countries contributing, you will see that it's clear that we need to strengthen the knowledge and evidence base we have to fill some of the major knowledge gaps in AMR. There are things that we don't know. There are things that we are not even sure whether we know them properly or not. We also need to have a coordinated system to synthesize the evidence that is available, including the evidence on gaps, across sectors and disciplines, so that we have a holistic view of what we know, what we don't know, and what are the most important things that we need to know to take effective action on AMR. And it's also very clear that all of this research activity needs the requisite support. So clearly, further evidence is required to understand what works in terms of preventing and mitigating AMR, what works in which contexts, and what works for whom.
Yeah.
It's clear that we need to be intentional, systematic, coordinated about how we do our AMR research. And it's clear that the research agenda needs to be properly supported, whether this is with funding, whether this is with capacity, whether this is with an enabling environment, to ensure that research is enabled to contribute all of these things that we have said it has to contribute to the fight against AMR. So I want to introduce a little bit of interaction to this presentation. If we could go to slido.com, either using the QR code or navigate to the website and use this code. I want us to take just a minute to record what we think is the most important research priority for AMR. I think the previous speaker put it excellently. This is an AMR youth forum, and the innovation, the ideas, and the perspective of youth are our future. So we are very interested in hearing from you what you think are the most important AMR research priorities. So we will just take a minute to receive your responses, and then we'll move on with the rest of the presentation. Okay, so the responses are starting to come in. I can see that we have 154 people online. It would be amazing to get as many responses as possible to find out, those of us here, what do we think? Because really we are the ones that are going to be setting the agenda for the future of AMR in Africa. Great, so we have quite a few responses. We have several that talk about surveillance, such as genomic surveillance, data collection, data, we have decision-making, but we also have those that are focused on treatment, such as phage therapy, pharmaceutical dosage, drug combination therapy, which is our current winner. And then we have prevention, so preventing infections, preventing resistant infections, sanitation and hygiene. We have new antimicrobials. Okay, so thank you all. Let's keep the responses coming because we are going to come back to our responses at the end of the presentation. For now, we are going to continue with the rest of the slides, and we'll come back to this at the end. Thank you all so much for participating. Okay, so we've agreed that research in AMR is critically important. What research should we be doing? We have started to consider that, but we actually have a One Health priority research agenda for antimicrobial resistance at global level. Responses from many different stakeholders in many different countries and settings. And this has been put together by the quadripartite. You have the FAO, the United Nations Environmental Programme, WHO, and the World Organization for Animal Health, WOA, formerly known as OIE. And they have taken through a 2-year consultative process where they've consulted many people and they've done prioritization on the responses received. This has resulted in 3 strategic objectives for AMR research at the global level. The first is to improve our understanding of the transmission of AMR, the drivers of this transmission, and the impact that it causes. So looking at the magnitude of AMR, trends in AMR across the different One Health sectors, social determinants of AMR, high-risk populations, but also how we measure AMR using our different surveillance systems. The second strategic objective is to strengthen the evidence base for interventions. So if we are going to intervene, we need to be sure that this is based on evidence, and we need to be sure that that evidence base is very strong. So we need to look at frameworks for prioritizing between interventions. We need to look at cost effectiveness of the interventions. We need to look at our implementation science and operational research, to look at sociocultural and behavioral insights, to look at interventions tailored to different contexts, to make sure that when we select interventions and the manner in which we implement interventions is based on solid evidence. And finally, we need to advocate for the prioritization of AMR mitigation. And this advocacy needs to inform policymaking. So we need to have an improved understanding of the socioeconomic impact of AMR. We need to make it very, very clear what is the value of investing in AMR mitigation, because policymakers always want to know why they should be spending funds. They need to be hearing what is the return on investment for whatever it is that they invest in AMR. We need to also look at the current policy environment and understand what are the barriers and what are the policy enablers. So economic evaluations, sustainability evaluations, investment and business cases to actually convince people to prioritize AMR is very important. So here we have at global level the 3 strategic objectives for research in antimicrobial resistance, taking a One Health approach. And to implement this in greater detail, there are 5 key pillars. We have transmission of AMR, we have integrated surveillance, we have interventions, behavioral insights and change. So we often hear about behavioral change, But before you begin to try to change the behavior of individuals or populations, you need to have a clear insight into why and how they behave. So we have not behavioral change, but behavioral insights and change. And finally, economics and policy. These are the 5 key pillars that cut across the human, plant, and animal health and environment sectors, but also the interfaces between all of these. In addition, we have 3 cross-cutting issues. We have gender, because we know that gender affects the occurrence of AMR. We have vulnerable populations, and we have sustainability. So these 3 issues cut across all the 5 pillars. It would have been great to go through the priority research areas for each of the 5 pillars in turn. And in the slides that I share, we will have that. But considering the limited time we have, we will simply go through the top 10 priorities. So the top 2 in each of the 5 pillars. So when it comes to AMR transmission, the 2 most important things that we need to research are the impact of the different IPC practices across One Health sectors. We have different IPC practices. What impact do they actually have in the development and circulation of AMR? Secondly, under transmission, we need to understand how resistant microbes are transmitted between humans, animals, plants, and environments. And we need to understand the impact of this transmission between the different sectors. And as with everything, because AMR, the burden and impact of AMR is highest in LMICs, the priority for all of these research questions is the highest in LMIC settings. When we talk about integrated surveillance, the priorities for research are to determine the key strategies to maintain quality integrated AMR surveillance. What do the optimum surveillance strategies look like? What are the minimum standards and resources required in terms of human resource capacity, in terms of laboratory resource capacity to have high-performing AMR surveillance systems, which are integrated across the One Health sectors, and to have these surveillance systems performing at scale. Secondly, under integrated surveillance, we talk about the fact that we already have a lot of surveillance data out there across the different sectors. How do we successfully integrate this, triangulate it, to look at the similarities, to look at the differences, so that in our integrated surveillance, we are able to very early on identify the development of resistance or the escalation of resistance or the movement of resistance in a new way. So early warning is important. How do we leverage on the existing surveillance data across sectors to ensure we have early warning of either the development or the escalation of antimicrobial resistance? When it comes to interventions, we need to know how those interventions that are proven to be successful, how do we translate them into different contexts? Say there is an intervention that has proven successful in Asia. How do we translate it into the context of Africa? In terms of different geographical contexts, in terms of differently resourced settings. How do we translate? How do we scale up? We also need to know what are the key challenges to systematic collection and analysis of data, specifically for risk assessments. because when we are able to measure risk, we are able to be proactive rather than reactive in the interventions that we take. And this will also help us to assess the impact of interventions across several disciplines such as epidemiology, economics, and sociology. For behavioral insights and change, we need to understand the structural challenges and barriers to those advantageous behaviors. There are certain behaviors that we know help us to prevent or mitigate AMR, but what are the barriers and challenges to people adopting those behaviors? How do we assess these and understand them in the different sociocultural contexts? Also, what are the strategies that can then be used once we understand the barriers to effectively adapt behavioral interventions that are successful from one context to the other? And finally, when it comes to economics and policy, how do we develop accurate socioeconomic impact assessments that are informed by data so that we can clearly understand the socioeconomic impact of AMR, particularly in low resource settings? And finally, what are the most effective policy options, regulatory frameworks, and financing strategies that we can use to sustainably tackle AMR? And we need to be looking at these policy and regulatory frameworks and financial strategies within the individual One Health sectors, such as human health or animal health, environment. But we also need to look at those that are cross-cutting across more than one sector, because this will give us the biggest chance to create an enabling policy and regulatory framework, but also to ensure that we have the financing and other resources available to have successful interventions and to prevent and mitigate antimicrobial resistance. Okay, so we have discussed the priorities at global level, but let's bring this down now to the national level. Because there's a certain amount of detail that you lose when you have when you try to gain consensus at global level. So of course, apart from this, we have several action plans for AMR at the global level. We have the Global Action Plan on Antimicrobial Resistance from WHO. We have the FAO Action Plan, which looks at antimicrobial resistance in agri-food systems. And you have the World Organization for Animal Health Global Strategy on AMR and prudent use of antimicrobials in animal health. Of course, we also have the Global Research Agenda. At the global level, we need to ensure that all of these documents are speaking to each other, are reinforcing each other. So one, that there are no contradictions, but that each of them reinforces the message of the other. When it then comes to formulating and implementing our national action plans, it's important for every national action plan to have a pillar on research. And within this, we need to, at national level, clearly prioritize our own national research agendas for AMR. And it needs to be clearly written within the National Action Plan that certain research is going to be conducted to address the knowledge gaps in AMR. It needs to be written clearly in the operational plans of our national action plans. It needs to be budgeted for, and there needs to be a monitoring and evaluation framework to ensure that these research actions take place. And some of the research areas that we can consider, of course, we've seen the guidance at global level, but within our countries, who are the most vulnerable populations that are suffering the negative impact of AMR? We also need to identify the key contributors to AMR, whether this is irresponsible use of antimicrobials within the agri-food sector or the health sector, whether it's within the formal or informal sectors. Let's know who are the biggest contributors to the development and spread of AMR, but also who are the most vulnerable populations. We need to invest massively in domestic research and development, looking at development of new antimicrobials, of antimicrobial alternatives, diagnostics, as well as vaccines. At the moment, many of these things which are in use on the African continent are developed elsewhere and imported into the continent at great cost. And we sometimes, or rather we often face issues of supply, issues of stock out. It is imperative that African nations take charge of this narrative and invest in research and development so that all of these things can be developed, can be produced and used by us for us. To make this happen, it will be necessary to have capacity building for research. So within our national action plans, we need to give space and budget allocation to human resources, capacity building for those human resources, laboratory resources for surveillance, training of all of the different actors. But then this capacity building should be needs-based. So we need to actually assess what we currently have, know clearly where the gaps are, and then plan our capacity building for research based on that. So, doing the needs-based assessments for capacity building is research in itself. And finally, for the research, for all of these research actions, we need to ensure that they are fully present in the monitoring and evaluation of our national action plans to ensure action accountability, but also sustainability. I think it goes without saying that national action plans for antimicrobial resistance must be One Health and should include all of the One Health sectors and their representatives at national level. Okay. So let's now try to relate this research agenda in AMR to action on the Sustainable Development Goals. When we look at One Health, we have humans, we have food and feed, we have plants and crops, the environment, as well as terrestrial and aquatic animals. And we've already said that a sustained One Health approach is essential to tackle AMR and to achieve the Sustainable Development Goals. And we can see here the 8 key Sustainable Development Goals that are affected by antimicrobial resistance. We have no poverty and no hunger, because of course, if you are sick and you cannot work, or the animals that you depend on for your livelihood have resistant infections, that affects our ability to achieve no poverty or no hunger. In the same way, we cannot achieve good health and well-being for all, while antimicrobial resistance remains such a big problem. Clean water and sanitation, we've heard in the last speaker's presentation just how crucial this is to preventing and mitigating AMR. And we also have partnerships, we have responsible and sustainable consumption, we have reduced inequalities, and we have innovation. So when we are talking about research, specifically sustained SDG 9, which talks about innovation, is key. And we need to accelerate progress in all countries. We need to innovate to secure the future. We need to collaborate for more effective action. We need to invest, and we need to strengthen accountability and governance. All of these key actions apply generally to AMR, but they are also applicable specifically to the AMR research pillar at the local, at the national, and at the global level. So we should keep this in mind when we make our efforts to try to advocate for research in AMR and to strengthen research in AMR. So we spoke earlier about bringing this very much to the local level. And we can see here once more the final results about what we think. The most important thing that comes out is preventing infections. We also have AMR surveillance and data sharing. We have drug combination therapy. And according to those of us who are here today at this AMR Youth Forum for Africa, these are some of the key factors that we think we should be focusing on when it comes to AMR research priorities in our countries and in our continent. So I want to thank you all for contributing to this. I want us to keep this in mind in everything that we do as we go forward in terms of being youth advocates for AMR and AMR research. And thank you very much for your attention.
Thanks so much, for such an insightful and informative presentation. I personally learned a lot from it. Of what I think we should be doing on AMR-wide research. And you explained how AMR was becoming a global and national level threat. And I was really surprised. We had over 5 million deaths associated with AMR and almost $100 trillion lost to AMR in the global economy. The first word that came to my mouth when I heard those numbers was, wow. I'm out of words. Once again, we are really, really excited and we are really grateful we had such a presentation from you. So at this point, we'd like to take a couple of questions. I'm very sure you have a lot of questions and we'd like to take a couple of them. So you can go ahead and react, just raise up your hand, and we'll give you the floor to voice out your questions. Or you can just, okay, I see some of the hands coming down. And you can just type in your question as well, and I'll read it straight away to Dr. Ivy. So I think Moses. Yes. So we'll take our first question for Moses. Please unmute yourself and go ahead with the question. You saying that? Hello, Moses. I think I have you still up. You can go ahead with your question if you want to.
Okay, thank you very much. Thank you. Can you hear me?
Yes, you can go ahead.
All right. Thank you very much. Good afternoon. Thank you very much for the presentation. My name is Moses. I'm from Nigeria, and it was a nice presentation. Please, my question is on the national plan in terms of research. I'm a medical researcher, and I tend to partake on the research plan when it comes to national level. How do I assess and get myself involved at the national level of researching for antimicrobial? Because I had interest in it. I've had experience with it. My mom has been a victim of AMR, and I tend to give back to the society through my research. How do I contribute to the national level? Because I've gone through the global level, I've seen the World Health Organization area of focus, but now I think we need to start from the national level, the grassroots, before we focus our mind on it. How do I bring my quota in terms of research to the national level?
Okay. Thank you so much for this very important question, Moses, which takes all of us closer to concrete action as to what we can do for AMR. Nigeria has recently launched her National Action Plan 2.0, which will be in effect for the next 5 years. This is available on the website of the Nigerian Center for Disease Control. And within the National Action Plan for Nigeria, which is a One Health multi-sectoral national action plan, you will find that one of the 6 pillars of the National Action Plan is research. Research is pillar number 6, and it has 5 strategic objectives under that research pillar. So I urge you to get a copy of the National Action Plan, look at what the country has decided are the research priorities for Nigeria, and see how in the research that you do within your sphere, within your career, within your institution, just do everything that you can do to make sure that you are aligned with those national priorities. In Nigeria on Friday, we are having a webinar for the AMR community of practice. So you can get involved at the national level with the AMR National Community of Practice. And this is a very, very good place to talk about what you are doing to disseminate the findings of your research and to let people know, one, that you are someone who is conducting research which is aligned with the national priorities, and then to share the results of your research. Thank you.
Thank you very much. Down in the comments, we have Kida, who from listening is right. So he says, I think we need research about, so I guess the latter part of his statement is the question. How does AMR influence the pathogenicity of microorganisms, and what are the implications for public health?
Yeah, so this is a good question, and this type of research is absolutely needed. So you will find this type of thing under the transmission pillar, which I presented when I was talking about the global research agenda. It's one of the key things that we need to understand about the transmission and impact of AMR. Thank you.
Thank you so much once again, Dr. Ayi, for such an informative presentation. Next up, incorporating behavioral science into AMR initiatives.
Jadoka, umeandika dance speaking.
Sorry, there's background noise. If we could just have everyone mute their mics, we'd be grateful.
Thank you.
So next up, incorporating behavioral science into AMR initiatives. Ladies and gentlemen, it is my pleasure to introduce our next speaker, Ms. Anika Buckle. So Ms. Anika Buckle, sorry, just a moment. So Ms. Anika Buckle works as a behavioral science specialist with the Food and Agriculture Organization, we know as FAO, where she applies social and behavioral science methods to reduce the need for antimicrobial in livestock rearing. For instance, by identifying barriers smallholder farmers face in adopting good biosecurity and animal health practices. She supports FAO country teams across sub-Saharan Africa and Southeast Asia in integrating behavioral sciences into the farmer field school approach. Prior to joining FAO, she worked with the United Nations Development Programme, that's the UNDP, and the Desire Center for Behavioral Economics based in the United States, Sri Lanka, and Kenya. She has authored and co-authored peer-reviewed publications in journals such as Frontiers in Public Health, Infection and Public Health, and Nature Human Behavior. Ms. Anika holds a background in psychology with a master's degree in peace and development studies. Wow, this is really impressive. I can't wait to hear what Ms. Anika has for us, and I'm very sure I'm not in on this alone. So Ms. Anika is here today to talk on the incorporation of behavioral science into AMR initiatives, shaping attitudes and actions for lasting change. Ms. Anika, you have our attention.
Thank you very much, and so nice to be here today. I have listened part of the previous presentation. It's a really, really nice setup for what's following now. So you've heard that behavioral insights and behavior change is one of the research priority areas. And so now we almost take a deep dive into this pillar as I'm presenting on the pharma feed schools and how we in FAO integrate behavioral science methods and approaches into project work, really. And I will present some of the methods, frameworks, narratives, so that gives you a good insight into this research pillar as well. I will just share my slides. So can you see it?
We can hear you. Thank you.
You can see it, perfect. So also today I'm presenting on behalf of my colleague Mark Caudell. He is the regional animal health social science specialist. So his background is in anthropology. My background is in psychology, and he works in the region in the ECTAD office, but he is based in out of Nairobi. And I lived many, many years in Kenya, but I moved to the HQ in Rome just a couple of months ago. So the way I'm presenting today is from more kind of a step-by-step approach. I'm introducing you to our work with the pharma feed schools and how that looked in terms of project implementation, and basically how we learned from a previous project phase and took those learnings into the next project phase. So I'm trying to be really pragmatic and show you really a good life or real life example on how project work is implemented and how we try to use those knowledge specifically around behavioral science and social science to advance our projects. So here on the, you see those three phases. Those resemble the project phases that we have conducted so far. The project is funded by Fleming Fund, and this is one part of a larger project. So we started off with knowledge attitude practice studies that was followed by pharma feed school based on the findings of the knowledge attitude practice studies. And then the next project phase, we integrated behavioral science. And now I'm going more in depth in each of those steps and phases. So in 2018, we conducted these knowledge, attitude, and practice surveys, short CAP studies, basically to just understand the situation in, what was it, in 5 African countries. So that was Ghana, Zambia, Kenya, Tanzania, and also Zimbabwe. And what we found was that most farmers really don't invest a lot in biosecurity, that they treat the animals themselves. So we work mostly with poultry farmers, but in any case also with other livestock, like in Tanzania, where we work with pastoralists and the Maasai. We saw that they treat their animals, and if they are sick, without the input from a professional animal health expert. Also very important for us, we identified that behaviors and decision-making that farmers make that are relevant for AMR, they make them throughout the entire production cycle, right? So from the day they get the day-old chicks up until they slaughter it, basically. There are multiple decisions they make that influence the spread and emergence of AMR. And then lastly, also very important, awareness of AMR was not associated with better practices. So we didn't see in our findings that those farmers that were more aware of that AMR is a problem, that they actually implemented better practices. So with those findings, oh, sorry, maybe a little excuse in what that means with the low awareness that doesn't necessarily translate into better practices. This is something, it was surprising in 2018, but over the last couple of years, there has been more and more studies actually showing this kind of knowledge action gap, as we call it in the social science, neuroscience literature, which is basically just a phenomenon that knowledge and practice or knowledge and behavior change are not necessarily directly correlated. So the relationship between what drives behavior change or between knowledge and behavior change is much more complex than just us assuming when we increase knowledge, when we raise awareness, then people will also change their behavior. It's not that straightforward. And yeah, there's a lot of studies emerging. Sometimes you see it in the title, sometimes you have to read a study. And I think it's really interesting once you learn about a knowledge action gap, you see it in a lot of papers emerging. So some mention it directly, that knowledge is not related to better practices. I have highlighted those paragraphs. And others, they say it more indirectly. So they don't call it knowledge action gap. They just have one sentence where they say, oh, we saw actually good knowledge amongst our farmers, but somehow that didn't correlate with better practices. And this is very interesting because what you also don't see in a lot of those papers then is that they discuss this. And often they even recommend for more education or more training. So this is something very interesting that I see in the literature as a psychologist in the veterinary science or biomedical science literature, that there seems to be this seems to be a phenomenon that's quite broad, and it's also beyond AMR or beyond animal health, of course. And it seems to be acknowledged, and researchers see it, but they don't quite put their finger on it. But it's there. So as you read more papers for your studies, you will see, you will maybe come across it, especially when you read those knowledge attitude practice study papers, that you often don't find a really strong correlation between awareness, knowledge, and behavior change. Also, but we seem to be obsessed with awareness and knowledge. And you can see that with the studies that have been conducted so far in AMR. So this also includes human health. No, it's not true. It actually just includes farmers. So when you look at behavior change studies and studies that try to understand what drives behavior change, you see that a lot of studies, what they're looking at, what they are trying to measure as this factor that drives behavior change, is knowledge is on the third place, and then first place is cost benefit. So basically, we believe that as long as we tell farmer about, let's say, biosecurity practices is beneficial for them, they will also change their behavior. So we somehow have this really strong belief that by communicating benefits of certain behaviors or increasing knowledge and awareness, that this will affect behavior and behavior change. And it's not that it's not true. Of course, it will affect behavior, but not to the extent that we have thought it would over the past years. So based on these CAP studies, and I repeat, we found that behaviors and decision-making, the farmers, the behaviors of farmers and the decisions they make are relevant throughout the entire production cycle, and there's a knowledge action gap. So we're looking for an intervention that would allow us to address farmers' behavior throughout an entire production cycle. And the Pharma Field School seemed just perfect for us. So Pharma Field Schools are an FAO approach. FAO is implementing this since the 1980s, so for a long time now. Originally, it's coming from crop agriculture, so not so much livestock, although the last few years that has changed a bit, and now there's more and more Pharma Field Schools in livestock farming. Also, not only FAO is doing it anymore, also other organizations implementing Pharma Field Schools. And the idea is that farmers come together on a host farm, where they rear livestock together for at least one full production cycle. And this host farm, when they come together, those sessions are facilitated by a specifically trained pharma-fiscal facilitator. So those facilitators, they're expert in the specific production cycle, often with an animal health background, but also they're learning specifically adult learning practices, community engagement approaches, because the pharma-fiscals are meant to be really community owned and really bottom up. So FAO often, or in this project particularly, so pharma-fiscals can be a bit different depending on the project or livestock system. But in our case, we provide the seed funding. And then from then on, the pharma-fiscals have to sustain themselves. And they can also make a lot of the decisions on how they want to design the pharma-fiscal themselves. And we do poultry pharma-fiscals because we saw that especially in poultry, antimicrobials are often misused. And in the poultry production system, they meet weekly. And they raise 2 flocks at the same time. That's very important because one is the experimental flock, where they experiment with more investment in biosecurity, with maybe indigenous knowledge, so falling back on herbal remedies, for instance. And the second flock is the business as usual flock, where they use antimicrobials as they usually would do. And then as they're raising it at the same time, they can directly compare how both flocks develop and how they later sell on the market. And this is often a very convincing scenario for the farmers, because we can tell them as much as we want that biosecurity is effective if they implement it. They need a proof of concept because their livelihood is dependent on it. So I would say, especially this experimentation part, and that it's a host farm, so they don't have to experiment on their own farm, is a really good mechanism for them to basically believe and see that actually if they invest in biosecurity, they can raise chicken without using antimicrobials or only when they need it, and that those birds actually sell much, much better on the market because they're believed to be more tasty and healthier. So this was project phase 2. We did an evaluation, really short. We have implemented this in 4 countries, also in Zimbabwe. And we did an evaluation and we saw great success. So this paper has been published. If you're interested, you can read in detail on the evaluation. But generally here, this is from Kenya, where we were able to also compare the findings with non-pharma-fiscal participants. We saw an increase in knowledge. We saw more positive attitudes toward AMR and animal healthcare professionals, and also an increase in prudent practices. And we saw that pharma-fiscal participants are 5 times more likely to engage an animal health professional in case they have a sick bird. So they reduce this kind of self-medication quite a bit. But you also see that the knowledge increase was much, much higher than the increase in prudent practices. And indeed, when we went to the pharma-fiscal participants' home farms, we saw that as much as promising as the pharma-fiscal findings were, we saw that still some farmers struggle to implement biosecurity practices and other good practices in a consistent manner. And as you know, for biosecurity, you have to be consistent for it to be effective. So we were wondering, very really successful in overcoming the knowledge action gap. And the true answer is we were only partly. We saw success, but somehow we could do more. Somehow there still seems to be barriers. And this is quite interesting. This just shows and demonstrates that behavior change is really quite complex. That even, so I mentioned the pharma-fiscals, they go for 6 weeks, since it's part of a project, even longer, sometimes 3 months. So farmers really identify with the topic around AMR. They really learn a lot. When we speak with farmers, they say it has been a life-changing experience for them. So they really appreciate having been part of a farmer field school. And it's a really long, it's not just a training, it's a really long process where they have a lot of ownership. And yet we still see some knowledge action gaps. And this gives you kind of a sense that behavior change is really just not a quick fix. It's really not something where we have all the answers and where we would need to invest much, much more effort in thinking when we talk about behavior change. So what we started to do, and here also again, there's a publication on this if you are interested. It's here linked on the bottom. What we started to do is integrating behavioral science to really understand what are barriers to behavior change. What influences behavior beyond just knowledge? And currently, this is the current project phase. We are experimenting with teaching our pharmaceutical facilitators and implementing those behavioral science methods. Because of course I'm a behavioral science specialist, but given that we are working with a pharma field school, it should really be owned by the facilitators, by the pharma field school itself. It shouldn't be so much people like me coming in and having quick sessions. It should be really more integrated in the whole approach. What we are trying to do, or what we found is an accessible approach, is to cut it down into 4 steps, starting by defining the problem or identifying the implementation challenge. So as the pharma field school is running, imagine for broiler farms, one cycle is around 6 weeks and we do 3 cycles. So they engage for around 3 months. Between the first and second cycle, so once they have sold the first flock of broilers, the facilitators ask if the good practices they have learned on the pharma field school, if they have challenges with implementing any of them. And so they list those challenges and then decide which challenge they want to talk more about. And this could be based on, for instance, what they think would have the most impact. Then the step 2 is understanding the barriers and enablers. So knowledge is most likely not a barrier anymore because they have learned it on the pharma field school. They have raised 2 flocks together where they already implement biosecurity practices. So it's very unlikely that there is a knowledge barrier. So step 2 tries to understand what other barriers exist if we have removed a knowledge barrier. And this is quite interesting, I think, also from a study perspective, because often, and as we work with pharma communities and we have interviews and we try to understand factors that drive behavior and behavior change, we often see knowledge gaps. It's not that it's not true that we still need to raise awareness and conduct trainings, but those knowledge gaps that exist, I sometimes I think hinder us from understanding what else is there because we focus so much on them. So working with farmers that already went through a training is quite interesting, I think, from a learning perspective, to see what else is there then once we have removed one major barrier. So they basically, in step 2, they come up with a list of barriers. And then in step 3, where you see co-design solutions, they then design solutions together as a pharma field school community. And then lastly, they implement those interventions and monitor and evaluate it. So that's done by the facilitators. You see here I have written COM-B and EAST, and I will talk more about this now because this is where really we use scientific methods from behavioral science. The first one in step 2, that's when we start introducing scientific frameworks is the COM-B model of behavior change. So the COM-B model of behavior change is from the literature. It's one of the most widely used behavior change models at the moment, because it's also the one that's mostly grounded in evidence-based and theory-driven. Meaning what they have done is they have scoped the entire literature on behavior change, because even behavioral science is a really big discipline, right? I'm a psychologist, there's anthropologists, there's economists, there's sociologists, and we all, even the behavioral sciences, we have a different idea what drives behavior change. I, as a psychologist, I of course say it's the internal processes, it's the human psychology that drives behavior change. And anthropologists would say, well, it's context and culture and the structural barriers. As sociologists would say, it's social norms, it's the social environment. Economists, of course, say it's incentives, economic incentives, cost-benefit analysis driven. So we all have different ideas and we all are kind of right. We just don't see the full picture. And this model has brought it all together to basically allow us to see a fuller picture of all the different drivers of behavior change. So it has three components: capability, motivation, and opportunity. And the model says that all of those three components have to be given for a behavior to occur. So a person has to have the capability, which is knowledge and skills, has the motivation, which are all the internal psychological processes, and the opportunity, which are all the external factors like the social environment and the structural barriers. And also legislation, you know, the legal frameworks in a country, what regulations exist, what economic incentives exist, that all falls into opportunity. And that then influences behavior, but also behavior influences those three components again, and also the three components influence each other. So for instance, if you think of foot bath use, this is how I often explain it on the pharma field schools, is if you work with a farmer, and farmers now learn at a pharma field school that they have that they can use a foot bath, that this is very effective, and they learn how to use it. And they develop the motivation to use it because they see the success on the pharma field school. But now you go to their home farm and you see they don't have a foot bath on their farm. You will not see that they change their behavior because they don't have the opportunity. They lack opportunity of the three components. In the same way, if a farmer has the knowledge of a foot bath and has a foot bath on his home farm, but he doesn't see the use of it because he uses antimicrobials for preventive measures, you will not see that they use the foot bath. And also sometimes farmers have a foot bath on their home farm because they rented it and maybe it came with a foot bath. And they know this is important for something, but they don't know, they lack the knowledge of how to use it effectively. Then you will not see that they use the foot bath or use it correctly. So we have to make sure all those three components are given. And of course, if we talk about those as drivers of behavior, at the same time, if we flip it around, they constitute barriers to behavior change. So in the pharma field schools, now we're using it as a framework to map out what barriers farmers have in implementing practices, the good practices they have. So for instance, on the picture on the right side, you can see the COM-B, and they do it for record keeping. So the facilitators ask for each category, do you lack knowledge of record keeping? Is there something that's not clear to you? Do you lack motivation? We have renamed as what mind. I think we said mind, internal processes, and attitudes instead of motivation. And opportunity we called external circumstances. So along those three components, the facilitators asked specific questions to fill basically up and categorize the different barriers. And it's really nice to see we have we have piloted this in Zambia, Tanzania, and Ghana so far. And next year, early next year, we are going to pilot this in Zimbabwe as well. And it works quite well. So facilitators can use it very well, and farmers. I'm always very impressed by the insights farmers have, also even I'm sometimes wonder when we ask about emotions or internal insights, they are really insightful and have a really good idea what kind of emotions they have associated and what kind of emotions or attitudes stop them from doing something. For instance, for record keeping, they say they are quite afraid of seeing what economic input they actually have to put into a farm they weren't aware of, for instance, that actually broiler farming costs them so much because a lot of the things they use, they thought are for free, essentially, or they didn't think of calculating their own labor costs and such things. Or when they see there's high mortality in their flock, that it makes them nervous. So they stop doing the record keeping because there's a negative emotion associated with it. Those things I find always quite interesting, and it's often things we don't ask so often. So even if you have research projects, this is a very nice, very easy framework that was also designed with non-behavioral scientists in mind, for you to use. And we are always very, very happy to share resources, share the guiding questions we are using. We are more than happy to support you if this is something that's interesting. You can use this as a theoretical or analytical framework in any kind of research you're doing around behavior. So also recent, we are using it in our pharma field schools. We have simplified it quite a bit. And for us, it's just important that farmers and facilitators think beyond knowledge gaps. But in reality, the COM-B, and you can see it here, and there's also the source, is quite useful for larger scale behavior change interventions. So in the green area is the COM-B again. You might recognize some capability, opportunity, motivation. And the red ring around it is the intervention functions. Because the COM-B doesn't only tell you what are the barriers, it also has a basically scientific way of saying, okay, if this is your barrier, if capability is your barrier, then the intervention mechanism to overcome this barrier is education. So it's not wild guessing anymore. Those mechanisms, those intervention mechanisms are directly linked to your barriers. So for instance, I think lack of capability is quite obvious, right? If there's a lack of knowledge, we want to increase knowledge with trainings. But what do we do if there's a lack of motivation? What intervention functions do we have then? And then you can go to this paper, there is a table, and you can go along this table and directly see, okay, if my barrier falls into this category, this is the proposed intervention mechanism. So you have a very evidence-based, bottom-up idea of what might work in the community you're working with. And then even nicer as a third tier, so that's what's gray, is policy categories. So, and this is where we are able to work bottom-up into actually policy level, based on actually research we have done with communities on the ground in rural areas, communities that are often left out. So the behavior change wheel, this is what it's called, with the COM-B in the middle, is a really nice way to bridge this gap and work bottom up to inform policies and regulations, because here you can see which policy category would respond to a specific barrier you have identified. So again, I can only encourage you to use it if you're interested and you don't know where to start with behavior or behavior change questions. This is a really nice model. And yeah, if you only take one thing away from this presentation today, it would be that knowledge and awareness is really important, but maybe you don't see the behavior change you want to see, because we need to see a more holistic picture of the farmer's reality. And for that, there's even frameworks you can use that help you. So lastly, step 3, this is why I showed you the behavior change wheel, because we don't make it so complex for farmer school participants. We don't want them to go into behavior change wheel and map out interventions mechanisms. All we want is that they think of barriers other than knowledge, and then to talk about these barriers and how they can, as a community, as a group, come up with intervention ideas. Because it's very important that those interventions don't come from us. It's a farmer fee school, so it's their ownership basically, and it has to come from them. And what we do is we give them the EAST framework. It's a very simple like acronym that outlines behavioral design principles, meaning if you want to increase uptake of a practice, make it easy, make it attractive, make it social, that means leverage social norms, and make it timely, that means think about when you implement intervention and where, right? A reminder when to wash your hands is not very useful if you've already left the bathroom. It's most useful before you go to the sink. So these kind of things just to help them come up with interesting ideas. So this is 2 examples they came up with. So the challenge they wanted to address, this was in the farmer fee school in Ghana, was foot bath use. And maybe you have heard it already, that the measurement or the arriving at the dilution rate with the disinfectant for the foot bath is sometimes difficult, because the bottle that usually holds the disinfectant, when they describe it, it's often not clear. It sometimes says something like dilute to 1% or dilute to 11%, but it's not quite a good instruction. What does that mean? Like, how many liters water do I need and how many milliliters of disinfectant do I need? So what farmers do is they just pour it into the foot bath, and that leads to overuse. So they told us that they don't use disinfectant for the foot bath because it's too expensive. But then we saw that they follow this practice. So of course it's expensive if they use a lot of overuse a lot of the disinfectant because they cannot measure it. So as a farmer fee school group, they said they would need a measurement aid. And they came up with this bottle you can see on the left side, which just by chance, this is something sadly wouldn't work everywhere. But in Ghana and the disinfectant they are using, it turned out that if you take the lid for measuring the disinfectant and take the bottle for measuring the water, if you combine that, you arrive at the dilution rate recommended by the brand. And this is fantastic because it removes cognitive load. That means they don't have to do the math. It's a visual cue, so the lid is really, really small, right? So that's a visual cue that you actually don't need a lot of the product. And then we hope that changes on the long term, changes the narrative around that disinfectant is too expensive. And another point, I think, is that, as you probably know, the foot bath on a farm, the foot baths often don't look the same. So they have to mix it for each foot bath individually. And with the bottle, it's quite easy now for them. On the right side, you have a poster they wanted us to design. Basically, that they lose profit if they don't regularly use the foot bath. And what I found quite interesting is that on the poster, it says a day without foot bath results in days without profit. You can see they don't talk about AMR. Because essentially what farmers told us is that, of course, they care about AMR, but what's more important to them is their profit, which means their livelihood. So for them, it was more motivating to see that the foot bath is related food BEF use is correlated to their profit, rather than that with food BEF use, they can stop the emergence and spread of AMR. This is more or less a byproduct and a second tier importance to farmers. And I think this was a good learning that if we want to motivate farmers, we have to talk about the things they care, because this is simply their reality, that they have to worry about their livelihood. And so we should talk about profit in this case, for instance. Do I have time? Sorry, I didn't check on time. I have a small like a 2-minute video, and then I'm done. Do I have time to show it?
All right, you can play the video.
I can show, okay.
The Food and Agriculture Organization of the United Nations, supported by the Fleming Fund, is implementing farmer field schools to reduce the need for antimicrobials at the farm level. Farmer field schools are group-based learning processes where farmers come together regularly, supported by a trained facilitator to exchange knowledge, learning practical skills, and solve problems collectively in a participatory way. For FFS to have a positive impact on animal health and reduce antimicrobial resistance, it is critical that FFS participants implement the good practices and lessons learned during FFS sessions on their own farms. However, putting these practices into action comes with often unexpected barriers. This is why FFS facilitators are trained to integrate social and behavioral science approaches into the FFS curriculum. These methods help facilitators do better, understand the challenges their group faces, and allow them to co-design solutions that help overcome these barriers. Identifying an implementation challenge. The group begins by listing practices they have learned during the FFS but find difficult to implement on their own farms. Understanding the barriers. FFS facilitators use the COM-B model of behavioral change to identify the type of barrier farmers are facing. The COM-B model suggests that for a behavior to occur, 3 components must be in place. 1, capability, which means the farmers must have necessary knowledge and skills. The second is opportunity, which means all external factors such as resources or environment must support the behavior. And motivation, which includes psychological factors. If any of these components are lacking, the behavior is unlikely to happen. Designing solutions. Following the FFS core principles, facilitators then use the EAST framework to design solutions. The EAST framework stands for easy, attractive, social, and timely. Behavior design principles that make it more likely new practices are adopted. Facilitators help farmers to think about how to simplify the practice that is easy, make it more appealing, that is attractive, engage others for social support, that is social, and implement it at the right moment, that is timely. Implementing and monitoring solutions. Finally, the core design solutions are implemented on the farms, and the facilitators help monitor progress to ensure the barriers are being addressed effectively. This continuous monitoring helps adjust the solutions as needed, ensuring sustainable behavior change and better adherence to good practices.
Mimi kama mwezeshaji, mafunzo haya ya COM-B yamenirahisishia kujua kwamba tatizo hili linaweza kwa nini lilikuwa linashindwa kufanyika mara ya kwanza, labda kwa shule labda kiakili au tu ni hisia za mfugaji zilikuwa zinasababisha asiweze kutumia hii modo. Lakini sasa hivi imenirahisishia mimi kama mwezeshaji kuwawezesha hawa wafugaji waweze kujua kwamba kumbe hichi kitu ambacho walikuwa nakiogopa mara ya kwanza kukifanya sasa hivi ni kimekuwa kirahisi na wao wameweza kuadapti. Na furaha kusema kwamba wafugaji wote katika mabanda yao wameanza kutumia footbath, wanatumia vijiua wadudu kama virid, na wamekuwa wakizingatia zile njia zote sahihi za kufuga.
Yes, so here's literature list, if you basically that summarizes anything I've said today. If you want to do an in-depth research, and also maybe to close the circle, bring it back to awareness and knowledge. As you see in the combi, so behavioral science, behavioral insights can also really tell you how to create awareness campaign, how to disseminate knowledge. For instance, there's emerging evidence that from psychologists, that if we refer to AMR as the silent pandemic, that people don't take it so seriously because silent seems like it's silent. it's not that extreme. So there's little things that we can learn from behavioral insights that help us in any kind of behavior change intervention, be it raising awareness or using the combi, for instance. And that's it from me. Thank you so much for listening and for your interest. Here's my email address. There's also the email address of my colleague Mark Cowdell. If you have questions to Pharma Fiscal specifically, if you want to learn anything about behavioral science, if you have questions about the combi, for instance, any other thing related to behavior science, please do feel free and reach out. I'm very happy to hear from you. Thank you.
Hello. Thank you. Thank you so much, Ms. Anika, for your presentation. I really enjoyed it. I had high hopes for it, and you really did too. I really enjoyed it. It was extremely informative, and we learned a lot from the different approaches that have been implemented, especially in integrating behavioral science methods into the FFS, the farmer field schools, and integrating these methods aimed at trying to overcome the challenges in these fields. We learned a lot from it. I know we all learned a lot. And once again, at this moment, we'd like to take messages and questions for Ms. Anika. So feel free to show a reaction, raise your hand, and we'll give you the floor to ask your question. Or once again, you can just drop down your question in the chat box, and I would read it directly to her. So, Maxwell, you've had your hand up for a while. Do you have a question for Ms. Anika? Please, if you do, unmute yourself and go ahead.
Yes, thank you very much for this insightful presentation. In fact, over the weeks, we have enjoyed a series of presentations. But there is one aspect that I am also beginning to realize, and it's also bothering my mind as in the question, and I'm happy that you are also coming from the FAO. My question is that can we, therefore, based on your presentation, agree that can we agree that majority of the causes of AMR is not coming from the farmers in Africa, but rather from a different perspective? And even I will not also go to agree that majority of the cases are coming from the human side. Basically, because I want to draw your attention, because in Ghana, what we realize is that we have a huge import of poultry and meat product from Europe, we have from US, and then from Brazil. And we know that, from statistics, the 70% of antibiotics are used, and majority of them are coming from these areas. And I'm happy that you are addressing the point that, even though I'm happy that you are also, teaching our farmers how to really take control of this. But I want you to address the point. I don't know whether probably you have looked at the statistics coming from Europe, as in the amount of antibiotics or antimicrobial that are being used in Europe, US, and then in Brazil, so that we can also prepare ourselves very well. Because I'm coming up with an article because I have the data that also is indicating that in Africa, we have to be very cautious about the import of poultry and then meat products that are coming from Europe, that are coming from US, and that are coming from Brazil. Because I foresee that majority of the antimicrobial resistant issues cases that we are having, it's because we are consuming huge amount of poultry and at the same time meat product from these countries. We have messed up with antibiotics. And I don't know whether maybe you are aware of it. Thank you very much.
Yeah. Yeah, there was more comments than a question. I mean, I
just want your response.
Yes. So my response is, of course, I'm a burial scientist, so this seems to be more a global trade issue, right? So I would I would extend my expertise here if I would talk about trade policies. But yeah, I know that in Ghana specifically, there is indeed a lot of import on chicken, and I saw that with the pharma fiscals we're implementing that it's more seasonal poultry farming, for instance. In terms of AMR, so we work more with rural communities, right? With implementing it in communities, and AMR for us is, since we are focusing on prevention a lot and reduce the need for AMR, our focus in this project is not so much statistics around global import of meat and how that spreads AMR or supports the emergency of AMR. So I think I'm the wrong person to make a comment on global trade and the effects on AMR.
Yes, I understand you perfectly, but what I want you to really agree that based on the works that you did, based on the researches that you did, it is evident that a majority of our farmers are not abusing antimicrobials in Africa. That is what I just want to find out, whether based on whatever that you told us, it's evident, so that we move to what is really bringing what is really causing or the super bug in Africa. That's it.
Okay.
All right. If there are any other questions, you can either type in the chat box or you just raise your hand and we give you the floor. All right. I will give 30 more seconds. If we don't have any question, it means that we have perfectly understood what Ms. Anika said. And if you are on the road and you are asked what is the COMBI model, you should be able to answer. Anyway, that is great, because at the end of the day, we all want to learn and take home something. All right, so I see no question in the chat box. It means that we perfectly understood Ms. Anita, and that's it. So Ms. Anika, thank you very much for for honoring our invitation. I personally know that I sent the invitation less than a month to the event and you accepted. So we are really, really very grateful for that. It's an honor to have had you here today. And it's also an honor to have had you deliver the last major presentation of our forum. So we are very, very grateful, and we look forward to having you in future events, because this is not just a one-time thing. We want to keep like tapping from your knowledge and everything. So thank you very much.
No, thank you for having me. It was an honor to speak in front of so many people. I see you had a great turnout today, and I'm very, very happy to see the interest in not only the interest in AMR, but also the more interest in behavior change and understanding drivers of behavior change. So thank you so much. I'm the one who should feel honored. I'm very happy I was here. Thank you.
All right.
Thank you so much once again.
So
Okay.
we have almost come to the end of the 3 days African Youth AMR Forum, but we are not yet done, please. We're not yet done. All right, so I understand that some of us didn't participate in all the sessions from day 1, day 2. Some of us might have missed some sessions, but we have good news. We are going to be sending to your emails like a summary of the previous sessions for day 1 and day 2. And also, we really wish to thank our media team, because these sessions, all the sessions have been alive on YouTube. So we are going to send you the links to the YouTube streams, and it's going to be there for as long as possible. Anytime that you want to like refresh an idea, you can always refer to it. So I'm going to send you guys the YouTube link to your respective emails, and I will as well send the brief report of the days, in case you just want like a summary of the key messages from each presenter from day 1 to day 3. So before we officially start the closing ceremony, all right, Gilbert, do you have anything to say? I can see that your hand is raised.
Yes, thank you. My name is Gilbert, and then I'm residing here in Kenya. And then the session from day 1 was very interesting and very informative. I enjoyed very much. Really, I got many informations. From day 1, I really thank you so much, and really it was very enjoyable. And I think we have something to do maybe in our community regarding to antimicrobial resistance. And then I have a short like inquiry or request. So when do we expect to get a certificate of participation? Thank you.
All right. Okay, thank you for that question. So regarding your certificate, if you receive emails on us, we said that you have to have attended 80% of the sessions, you must have filled the pre-evaluation survey and the post-evaluation survey. The post-evaluation survey link will be shared tomorrow. Tomorrow, 8 a.m., you receive the link to the post-evaluation survey. And the team in charge of certificates will work on it, but best believe that, let's say latest, because we are very large, we are like close to more than 500 people that will be needing certificates. So within 1 month from now, you'll be getting your certificates. That is, people should not bother. The certificates are assured you are going to receive your certificate.
Thank you so much.
All right. So I'm going to give room for us to give our feedback from the session. But before that, I would like us to like watch a little cool animation video on antimicrobial resistance. Our tech. Mr. Austin, are you ready?
No, the video is ready.
All right. If you are ready, I give you the floor to play the video. It's just a
Okay.
4-minute video, and it's really short, brief, and very informative. We can't get the sound. Can you try to reshare? Try to reshare with the sound.
Okay, my bad. Just a moment.
All right. So in the meantime, you can just like text in the chat box. Tell us your mood. All right, it's fine now.
How's the studying going?
Yeah, I've been working on COVID and pandemics, and now learning about antibiotic Armageddon.
Antibiotic what?
Antibiotic Armageddon. Basically, we're going to run out of antibiotics very soon.
Antibiotics are like those drugs that get rid of infections, right?
Yeah, that's pretty much it. Bacteria that can cause infections are increasingly resistant to all antibiotics. Some call these superbugs. We've been using these precious medicines like sweets in humans and animals.
Did somebody say superbug?
Ethan, really?
This antibiotic thing Marley was talking about does sound really disturbing.
Exactly. Just like climate change, none of us will escape this.
Ooh, really? Yet another scare story?
Listen. By 2050, it is predicted we will be back to the Dark Ages, where medicines we relied upon for so long won't be there.
2050? Who cares about 2050? This is now.
That means if you fall off your beloved motorbike, you too may have an untreatable infection and possibly die. By 2050, well over 10 million a year will die of antibiotic-resistant infections. It is way worse than COVID. It is happening right now in countries across the world. We don't have until 2050.
Come on, Marley. We're young and fit. What could go wrong?
Can't believe it. That he died like this? A simple bike accident, minor surgery, and then being eaten by an incurable infection.
We all knew it was going to happen to one of us. It was just a matter of time. We are the lucky ones. Dozens have died in my hospitals from the same drug-resistant bacteria.
You kept on warning us about antibiotic Armageddon.
How did we get this so wrong?
Good question. The evidence was all there 10 years ago, but nobody listened.
And, as usual, we were far too late.
This is just the beginning. And by 2050, it will be worse. Much worse.
Right. Thank you very much, our tech, for playing this video. All right, for those asking for a link to the video, I am going to, let me just look for it. I'm going to include it in the chat box. It's actually a YouTube video, so you all can have access to it. All right, so thank you very much. So before we debut our official closing ceremony, I would like to ask, are there people that would like to tell us about their experience attending this forum? If what has your experience been like? What are your remarks? We want to hear from you. So you just quickly just indicate by a hand show, or you can just type in the chat box and we are going to read. Let me look for the video link while waiting. Are you guys shy to tell us about your experience? Please don't be shy. We're here to listen to each other. All right, Joylene, you have the floor, please.
Okay, thank you, ma'am. Am I audible enough?
Yes, we can get you.
Okay. I just want to thank you all the organizers for such a very wonderful forum for us to learn, to exchange experiences as well. And one thing I'd like to thank you is that in terms of reach out to speakers who are already in field, they were well prepared for this forum and we learned a lot from that. I think it is quite a wonderful thing to have like experience from those who have been practicing, who have been doing AMR programming. So that I want to also thank you for that one. I think that's the key takeaway from my end, that I think also it comes to your planning in terms of reaching out to them, because I understand also the nature of the panels. Those are people who are very busy in field, but then I'm sure you managed to reach out to them and managed to convince them that they should train future global health experts. And yeah, I look forward to be sharing that experience, that one time during WOW 2024, we had this and we implemented. So keep it up and thank you so much.
Thank you. All right, Milimo, you have the floor, please.
Well, thank you so much for the opportunity to air my views thus far. I'd like to state that to the organizers of this very incredible platform, you've been doing a very good and tremendous work. We've really learned throughout the process. It's really been an incredible platform where we've been fully engaged and sharing experiences and best practices around AMR, how each and every one of us can take part to ensure that we fight this global crisis of antimicrobial resistance. It really doesn't take those that are in the health sector to fight AMR, but it will require multifaceted approach, different industry leaders joining hands, coming together to fight against AMR. It's really been incredible learning insights around AMR and SDGs, AMR and infection prevention and control guidelines and mechanisms from facility to community levels. Very insightful information, really. It gives us an assignment to initiate projects in our communities to ensure that we utilize this information that we have gained to be the change that we want to see in our communities. And it starts right from where we live. Thank you so much.
Thank you too. We're glad having you. All right, let's move to the next person. I see Gilbert. Yeah, Gilbert, you have the floor, please.
Thank you so much once again. And then my takeaway, maybe it is based on from day one with Dr. Paul, has taken us through about antimicrobial resistance, how it is linked with SDGs of United Nations. So I got more information about this, how antimicrobial resistance is linked with SDGs and how, and the solution and the suggested solution that we should take. So it was really exciting and very informative because before I didn't know this. And not only that, but having known about it, the solutions, I was able to go deep and get more knowledge about it. And I also got information about how policymakers would address this issue of antimicrobial resistance, which is linked with SDGs. So really, it was very informative, and I enjoyed the sessions and also meeting with experienced people talking about antimicrobial resistance. Thank you so much.
Thank you too very much. All right. I don't know if I pronounce the name right. Habibullah. Please excuse if I have not properly pronounced your name. You have the floor.
Good evening, everyone.
Good evening.
I want to say a big thank you to all the organizers. You guys did an amazing work. It's been an amazing 3 days webinar with you guys, and the speakers they are amazing, and they know what they came here for, and they really delivered well. At a point, I was asking myself, where did you guys handpick these amazing people from? Like different from all over the world, from India, from UK, from Nigeria, from Kenya, from different part of the world. I was really amazed, and I really enjoyed that. And at a point, is just like a motivation for us, those of us that are already part of the advocacy about this AMR in our locality. It's kind of we saw that we are not doing enough. Just like Dr. Chuko was saying this morning about the IPC, we are not doing enough in our personal lives, the sanitation, the hygiene, and the vaccination. We've seen some areas and fields that we are overlooking, just telling them okay, not to overuse that. That's why we're leaving some parts like vaccination and sanitation. So it's been an amazing. Although I missed the first day, I was with them yesterday, and it has been an amazing 2 days programs to you guys, and hope to witness more. And I'm seeing that this one is 2.0, and I imagine there was a 1.0. So, and I'm looking forward to see a 3.0 next year by God's grace. And very much.
Definitely it will be 3.0. We did not start to stop now, so we'll have to keep educating ourselves every year on
All
AMR.
right. All right, thank you very much. It's been an amazing. You just made mention of something like you talked to Dr. Aneka like a month before the program. That means you guys have been working on it months before now. So
You know that these speakers, they are very busy people, and while it's a very chaotic week. So for you to even get a speaker, like you have to start booking them way ahead of time so that they can even squeeze into their calendar. So we
that
are
is
very glad that
amazing.
we're able to
A
get
big
them.
shout out to all of you, all the organizers, both
Thank
behind
you
the
very
screen,
much.
and thank you very much.
And also a big shout out to you, the participants, because if we invite speakers and we don't have people who actually listen to these speakers, then it's not worth it. So for it to be a success, we give a shout out to the speakers and also give a shout out to all of the participants. You people made it worth it. And we are glad that we are receiving such feedback from you all. All right, let me just quickly check in the chat. All right, Frederick, thanks very much for your input. We are honored. Cornelius, wow. Thanks for attending. We're grateful. Wow, thank you. Please, can you mute your mix? Please, can you mute your mix? Thank you very much. All right, Innocence, thank you very much. And WOW Week does not end today. WOW Week is from the 18th to the 24th. So if in case there are any other opportunities for you to actually participate in WOW, please do. Till this Sunday, the whole of this week is dedicated to WOW. So we hope to like keep seeing you guys engaged, just as you started the week with the forum. The remaining days of the week, please just keep being engaged, LinkedIn, challenges, whatsoever. Please, I shared the video. I shared the link to the video earlier in the chat. I don't know if you guys saw it. It's actually a YouTube video, so you can easily have access to it. All right. So before we move to the closing ceremony, please, Miss Ivy, are you ready? We have a
Yes.
very important.
Sorry. Hello. Can you hear me?
Yes, Ivy, morning.
Can you hear Eleanor? Hello.
This with her network.
Oh, okay.
Yeah.
It has been a very incredible session, and I loved hearing from all of you today. As we near the end of today's event, I'm honored to introduce our final speaker, Dr. Mayowa Akinpelu. Dr. Mayowa is a medical doctor and a member of the World Health Organization's Youth Council, serving as a youth advisory to the WHO Director General and the WHO senior leadership to foster young people's participation in shaping global health. He is also a member of the Youth Engagement Task Force of the UNICEF Generation Unlimited 9JA, a public-private youth partnership platform aimed at equipping 20 million Nigerian youth with green skills and opportunity to economic empowerment and social impact. As the executive chairman of the Africa Public Health Student Network, Mayowa leads efforts to strengthen public health systems across African countries. His initiatives through the Africa PHSN addresses pressing health challenges in vulnerable communities with a focus on youth-driven approaches. He also serves as chairperson of the African Youth Antimicrobial Resistance Alliance Task Force, a role in which he leads over 600,000 collective youth voices and champions mitigation efforts against AMR under the auspice of React Africa and in collaboration with organizations like Africa CDC and UN Quadripartite. Mayowa is deeply committed to the SDGs and the African Union's Agenda 2063. He advocates for sustainable youth-centered health solutions that align with these frameworks. His efforts extend beyond immediate health initiatives to include resilience-building strategies such as pandemic preparedness, climate adaptation, and system reforms, all with the goal of creating a healthier, more equitable Africa for future generations. That was a very, very comprehensive work experience, and he's definitely the perfect person to close our event for us. Dr. Mayowa, thank you for gracing us with your presence. You have the floor now.
Yeah, thank you very much. I hope I'm audible.
Yes, you are.
Yeah, I usually don't like to do the dirty work because I'm sure not many of us want this event to come to an end, but certainly I've been tasked to bring this to a close. So definitely, we all know that this AMR Youth Forum cannot be a success, a resounding success, without the participants. And as I can see, even down to the end of this event, your energy remains 100% and then some. AMR discussion generally goes beyond statistics. It's human lives and livelihood that are actually affected. We all know one or two people who must have been infected with resistant pathogen, and AMR also is, as the case is, actually makes day-to-day life a lot more riskier. from injuries on the football field to dental clinics to childbirth to simple surgical procedures like we saw on the antimicrobial resistance Armageddon. We know that this actually have a way of putting us at the edge of death. So definitely, we are hoping that this discussion can be followed up with action, and then the doses of energy that you brought to this event can be translated into community level interventions. Some of us are already doing a lot of work in the space of AMR, but I'm sure we all have our various roles to play. We've certainly seen from this event that, as a proof actually from this event, that champions of AMR actually spans the entire continent. And then we have people who are willing to engage in this process and also be a part of the solutions to mitigate antimicrobial resistance. I would want to, before I put this to a complete close, appreciate the organizing committee, particularly Eleanor, and then who has actually coordinated this. I'm also part of the organizing committee, so I know the work that she has done in making sure that this actually is a success. The tireless effort has majorly orchestrated a brilliant forum and a symphony of ideas, and more or less a launch pad to transformative impact for us as young people. I would also want to appreciate everyone behind the scenes that have done, contributed one way or the other to the success of this event. Also recognizing our collaborating partners, IPSF, the African Youth AMR Alliance Task Force, which I also represent as the chair, AAA, which is Alliance Against Antimicrobial Resistance. We have Dusty Blue Foundation, Africa CDC, the Institute, Africa Public Health Student Network Initiative, RBA Initiative, React Africa, Aware Ghana, IVSA, FAMSA, GSA, and the intentionally selected speakers and facilitators that have given us a well-measured dose of knowledge and impact over the last 2 days. We want to completely appreciate every one of them. And I'm sure I've appreciated the participants, and I continue to say I'm impressed by the energy. You guys have kept an 100% energy from the beginning down to the end. But we all need to remember that meaningful youth engagement goes beyond, having a seat at the table. It's actually turning the table to a launch pad for meaningful impact in our various communities. We come from separate communities, which means we have a lot of work to do around the discussions that have been had, from water hygiene, sanitation to vaccination, advocacy, and some of these activities that we can do within our communities. So the prescription from me is very clear, and it is, I'm just going to give a one-line prescription. The action